The trapezoid is the smallest carpal bone in the distal row. It contains 4 articular surfaces, which are all in contact with one another, and 2 non-articular surfaces. It articulates distally with the base of the second metacarpal, proximally with the scaphoid, medially with the capitate, and laterally with the trapezium. In this video, we're going to use a right hand model and a left individual bone specimen. The distal articular surface for the base of the second metacarpal is described as triangular shaped, with the apex palmar, and it contains a pair of concave facets that are separated by a ridge. In about 33% of people, there is also a small oblique facet for the third metacarpal. The lateral surface contains a trapezium facet. It is convex shaped and located proximal to the V-shaped cleft. The proximal surface contains the scaphoid facet. It is quadrilateral shaped and slightly concave. It is continuous with the facet for the trapezium. The medial surface contains the capitate facet. It is concave from dorsal to palmar and is rectangular shaped. The dorsal surface is larger than the palmar surface. It is flat and non-articular. It allows for the attachment of ligaments and also contains nutrient foramina for entry of blood vessels. The palmar surface is non-articular. It is roughly rectangular shaped and is covered by ligaments, and it also contains nutrient foramina for entry of blood vessels. The palmar surface courses into the lateral surface, forming this V-shaped cleft. This V-shaped cleft separates the articulations for the trapezium and the base of the second metacarpal. The palmar surface also gives origin to the deep head of the flexor pollicis brevis. If you remember, the superficial head of the flexor pollicis brevis muscle originates from the palmar surface of the trapezium and the transverse carpal ligament, which is really the middle portion of the flexor retinaculum. In some people, a few fibers of the oblique head of the adductor pollicis also originates from the trapezoid. The trapezoid receives its blood supply from branches of the dorsal intercarpal and basal metacarpal arches, as well as the radial recurrent artery. The vessels enter from the 2 non-articular surfaces, the dorsal and the palmar. Usually, 3 or 4 vessels enter from the dorsal surface, which supply about 70% of the bone, and 1 or 2 vessels enter from the palmar surface, which supply about 30% of the bone. It's important to know that the dorsal and palmar vessels do not anastomose. As a general anatomic principle, a lack of intraosseous anastomosis often increases the risk of an AVN, or avascular necrosis. However, the trapezoid rarely undergoes an AVN because although it lacks intraosseous anastomosis, it benefits from having several extraosseous vessels that provide vascularity. The trapezoid is described as the keystone of the carpal arch. It is well protected as it sits tightly within 4 bones and is held in place by a number of strong ligaments. Therefore, it has very limited motion, which is why isolated dislocations and fractures are extremely rare. There are mostly only case reports of isolated dislocations and fractures. And when it does dislocate, the trapezoid can dislocate dorsally or palmarly, although most times it will dislocate dorsally. And trapezoid fractures account for less than 1% of all carpal fractures. For side determination, if you go through a lot of anatomy textbooks, the authors will describe it as being shaped like a boot. So I like to think of it as being shaped like a foot, with this being the ankle joint up here, and this kind of being the plantar aspect of the foot, with the toes over here. But really, for the bone, this is the dorsal surface, which we said was larger, and up here is a palmar surface. And here is that V-shaped cleft that we talked about. So one of the methods that I use is you hold the bone where the dorsal surface, which is larger, you have that on the ground, and you have the V-shaped cleft pointing towards you, with the palmar surface up and away. So again, the larger dorsal surface is on the ground, the V-shaped cleft is pointing towards you, and the smaller palmar surface is away from you. So if you imagine this as being a foot and the ankle, the toes over here, the toes will point to the side from which the bone came from. So in this case, the toes are pointing left, so this would be a left specimen.